is a 45-year male patient. He presented to the hospital with complaining of a distended abdomen. Since month, firstly it was not so distended. Now it was gradually distension is increasing. So we have to find the causes of distension. Like there is basic causes of distension is 4F. One is fat, one more is fetus, one more is flatus, one more is fluid. So in the pregnant ladies, the fetus may be there for the cause of distended abdomen. One more is the some fat will also be the causes of the distended abdomen. In some patient, they will have a gaseous distension, that is flatus is the cause of distension. In this patient, he is having fluid. So what you have to do is, there is something called ascites. We have discussed ascites now. What is meant by ascites? Definition is, there is something fluid collection in the peritoneal cavity of the abdominal cavity is called as ascites. Technically, to say that fluid is, there is more than 25 ml fluid in the peritoneal cavity. If it is collection, it is called as ascites fluid. So what you have to do is, we have to go ascites. There means you have to go for the causes of ascites first. So what are the causes of ascites? In the liver, most of the causes of ascites is usually in the liver cirrhosis patient and the alcoholic patients. They will have ascites only. So one more thing, what are the other causes of ascites? Even a simple hypoalbuminemia will cause ascites, and renal failure will cause ascites, and the cardiac failure will cause ascites, and the low protein, that is hypoalbuminemia, will cause ascites. These are the causes, main basic causes of the ascites. In some extra, like in TB ascites, in tuberculosis abdominal TB, that will also cause ascites. So what you have to rule out is, if any patient we present with ascites, means we have to tap first. So we have to remove some fluid and we have to send for the analysis. So what are the fluid analysis have to be sent, and you have to search for the other causes of the ascites. Clinically, if the patient is having history of alcoholic intake, and he just observe this. See this, he is having huge jaundice here. Okay, you can see clearly his eyes. Okay, conjunctiva. You can nodri. See this yellow color. This much jaundice is there. Nalgi tegiri. Nalgi ಮ್ಯಾಲೆ ಎಬ್ಸ್ರಿ. See this yellow tongue also, below tongue yellow is there. So this he is having ascites. He is having jaundice. We have to see for the pedal edema. So yes, he is having pitting type of pedal edema. You can see this. Not too much, but he is having pedal edema. You can see this. Yes, he is having pedal edema. So what you have to do is, we have to find the causes first. If there are some criteria which is called, if a patient is having ascites secondary to cardiac failure, he should have some features of congestive cardiac failure. What are the features of congestive cardiac failure? With history of dyspnea on exertion, like he is having dyspnea on exertion since 15 days, 20 days something, and with pedal edema and with ascites with increased jugular venous pressure. See, we can see this increased JVP. You can clearly see this JVP now. See this. This is a whole increased jugular venous pressure. So this much huge JVP is there. So yes, he is having features of cardiac failure is there, but he is having history of cirrhosis also. So what you have to do is, we have to, one more, we have to rule out the renal causes and renal failure. He is not having renal failure because his renal profile, that is urea creatinine, everything is normal. He is having high bilirubin. His total bilirubin something 5 or something 8 is there. So nothing to worry. What I am conveying is, I am doing some ascitic fluid parasympathetic. Like I will tap this fluid and I will send the analysis. There is some test to diagnose. Like there are some clinical tests to find the ascites. So one more is, there is something called fluid thrill test. So what is meant by fluid thrill? We have to make the patient put his hand in this position like this, and we have to put our left hand in this side. We have to tap with right hand. We have to tap in this area. If you tap here, we can feel the vibration in this area. So it itself indicates that there is something fluid in this area that is freely mobile. If you tap here, I can feel the vibrations in this area. So this is called as fluid thrill test. So to conduct a fluid thrill test and to convert a fluid thrill, minimum 200 ml, that is 2 liters fluid is required to do this test. Like if you are having 2 liters fluid, the test will be positive. One more, this is called a fluid thrill test. One more is shifting dullness. There is something called a shifting dullness. We have to do percussions here from here. We have to percuss like this. You can see dull resonant node is there. Resonant node means actually air is having, usually if it is a water or fluid, that more it will collect in the below side because of the gravity, and air will collect the above because of the gravity. So the above, see, you can hear the sound also. This is a very resonant node, and if you same can percuss here, this resonant node suddenly turn into dull node. Resonant, resonant. Yes, this is dull node. What you have to do is we have to make the if I am feeling dull node now here, here is resonant node, here it is dull node. I have to make the patient to turn on that side so that fluid will go this side, and this dull part will convert into resonant part now. ಸ್ವಲ್ಪ ಆ ಕಡೆ ಹೊಳ್ರಿ. Okay. We have to wait some seconds to just go for the fluid to turn this way. I think now fluid go towards that area. So previously I was feeling dull here. So now see this resonant dull node. So this itself indicates that he is having fluid, that too freely mobile fluid. See, this is having shifting dullness. So now it is resonant and it is dull. You just make the patient feel like this, then the fluid will go both sides. So now I am feeling resonant. So this is called as fluid. What you call it? This is called as shifting dullness. And shifting dullness, to form a shifting dullness, there is something called, if the freely mobile fluid is there, means it will move like anything. If in some patient in abdominal TB or in patient of tuberculosis, the ascites secondary to tuberculosis ascites, so they will have loculated effusions, like loculated ascites fluid may be there. So in this patient there will no changes of the fluid, and the shifting dullness will not be present in those patients, because there are so many adhesions in the tuberculosis. Those adhesions will cause loculated ascites. So because of the loculated ascites, we can't find this shifting dullness test in those patients. So what we have to do, we have to just percut. We have to do tapping now. After tapping, we have to send for the fluid for the analysis. What are the fluid analysis we have to send for protein, glucose and chloride, and some to rule out any transitive exudative. So in this fluid, the protein itself indicates that it is a transitive exudative. If you find the protein is more than, like if the protein is more than 2.5, it is the exudative fluid. So if the protein is less than 2.5, it is a transitive fluid. So usually exudative fluid that is more than 2.5 is seen in the patient of TB or in any other tumors. That is called as exudative fluids. So transitive fluid means there is a less than 2.5 is a transitive fluid. Transitive fluid is normally seen in ascites and any cardiac failure patient, renal failure patient. Those things will cause transitive fluid. So that to see this, we have to send for the protein level, and glucose chloride is secondary. One more test is called as ADA test. So ADA test is specifically to see that abdominal TB. So ADA, if it is more than this ratio, more than 16 thing is there. If it is raised, means we have to think that it is a ascites fluid secondary to tubercular origin. So we have to perform some tapping now. Just come this way. You have to clean the part here. We can prick here because we should not. There is some starting people, they will think that he is having huge what is called intestines in this area. What happens if we prick intestine? No, it will not, because intestine is a retroperitoneal organ. It will sit in the behind the abdomen. So what you have to do is you can prick easily here. You have to take bony prominent. You have to take this bony prominent. From the bony prominent to 4 to 5 fingers above the bony prominent. From the below umbilicus, you have to tap. Here you have to see. Yes, it is there here. How is it? ಮಾಡ್ತಾ I am connecting this IV line to this needle. A big bore needle I have to pink color. So how to prick is, we have to firstly, there is something fluid in the peritoneal cavity. You should not direct, just you have to prick like this and just wait it straight. Now there is no fluid, you can see the fluid after tapping. Sun सोच रहे on. Yes, the fluid is coming now. You can see this fluid, you can show the fluid till there. Fluid is coming now, you can sit there. See, the fluid is coming very fastly. So fluid color is normal, there is no any white color of fluid anything. If it is white color of fluid, it is called as chylous ascites. The chylous ascites is usually seen in some cancerous conditions, everything. Now fluid is normal condition. Fluid is normal now. So we are tapped here a sticky level. Okay, we have to do this. See, this very fast is coming. So what you have to do is we have to do some therapeutic and diagnostic ascites tapping. What is meant by diagnostic ascites tapping is, if the patient is not having too much ascites and the ascites is not causing so many breathlessness, what you have to do is you have to take only a 20 ml syringe, you have to prick, and you have to take the fluid for the testing. You have to test for the same protein, glucose, chloride, cell type, cell count, and ADA test to rule out any other causes. It is a transitive or exudative. Is it involve any malignant cells, or is it having a secondary to TB, or is it only the transitive secondary to alcoholic or cardiac failure, anything that have to rule out by those mechanisms. Now he is having huge ascites and he is having breathlessness also. So he is having orthopnea. So how it will cause orthopnea? Any dyspnea or breathlessness orthopnea, because of the huge fluid, the diaphragm pressure will increase, so that the patient will have orthopnea when he sleep, and the patient will have dyspnea. So other signs of, we are removing now one little fluid, that is nothing to worry. So after removing, you have to see for other signs of, is it a cardiac ascites, is it a renal ascites, or is it a ascites secondary to liver cause? We have to find. If it is ascites secondary to liver causes, we can find the jaundice is there. We are having clearly history of alcoholic is there, and we are finding clearly other histories of liver failures, there is gynecomastia and everything. Other causes of there is loss of libido, there is hair, loss of axillary heels. So you have to rule out other causes of the liver failure. And if it is a secondary to tumor, you should be rule out the like weight loss history, everything. If it is secondary to TB, you have to rule out the abdominal TB. You have to test for this, and we can having a history of all cardinal features of the tuberculosis. So this is the procedure. And only thing is, one important thing, shifting dullness, it is seen in every patient normally. In TB patient, they will have some local diffusion, so shifting dullness may not be positive. And to cause a shifting dullness, the patient will have almost 1 liter of the fluid. To cause a fluid thrill test, they should have 2 liters. Okay, this is the minimum. We don't know USC, anything is not there. We have to assume how, if the patient will ask how much fluid, how much liter may be. Yes, we have to do for the fluid thrill. If fluid thrill is positive, we have to say that more than 2000 ml fluid is there. If we find the shifting dullness, more than 1000 ml fluid is there. So this we have to rule out. Okay, thank you.